Aibovan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. Today we are going to be talking about one of the most prevalent and most widespread conditions across the world as it is today. And coincidentally, the World Obesity Day falls on the 4th of March. So today we are going to be talking about obesity, which has become a real world problem causing real medical conditions across the globe. So today we are in conversation with Dr. Ahmad Rushdhi. He is a consultant nutrition physician at the National Hospital of Sri Lanka. So it is a great honor and privilege to welcome him to our studios this evening. A very good evening to you, sir, and thank you for joining us.
Good evening, Dr. Dilshan and dear viewers.
So first and foremost, sir, now I said we are going to be talking about obesity. So I think it's a very loosely used term across the world. So some people call someone overweight, some call themselves obese. So what is this obesity and being overweight? Are there any particular definitions?
Yeah, there is a BMI category definition led by the World Health Organization. So according to the World Health Organization classification, BMI, that is the body mass index, where your weight is in kilogram and divided by height in meters, then you get a value. So that value between 18.5 to 25 is considered normal weight, and below 18.5 is underweight, and between 25 to 30 is categorized as overweight, and anything more than 30 is classified as obesity. If within obesity, then between 30 to 35 is class 1 obesity, then 35 to 40 is class 2 obesity, and more than 40 is class 3 obesity, and if it is more than 50, it is called super obese. I have to mention a small thing there, but yes, there is a cutoff value for the Asians. Our population, the cutoff value is between 18.5 to 23. So if in our population it is if it is between 23 to 27.5, we can consider them as overweight, and more than 27.5 will be classified as class 1 obesity.
So as you say, when it's obesity or being overweight, there's a very objective assessment according to your body weight, how your body weight is distributed with your height. So now when we talk about obesity, I know I said it's a very common condition now and the prevalence is increasing, but how is it actually in Sri Lanka and how do we compare to the Western world?
It's a good question, Dr. Dilshan. When we I have to mention one more thing regarding the BMI values. Although we go by the BMI values, that can be varied. Sometimes if a person is bulky and he is muscular, he could have a BMI, high BMI in the range of 26, 27, but his fat levels might be low. Then we have to go for waist circumference, the circumference of waist, and it has to be between 90, it has to be 90 for a male of Asian origin, and it has to be 80 or less for a female of Asian origin.
So when you say 90, it's centimeters?
In centimeters. Okay. So it's like 36 inches for a man, the max, and 32 for a female. So that is what more the disease correlationship between diseases or metabolic syndrome or any other conditions, waist circumference plays a major role.
That is a very important and interesting point, sir, because as you correctly said, even though the weight distribution, it's not just the fat that contributes to the weight, there is a dense muscle mass which also contributes. So for sportsmen and whoever who's involved with all these physical activities, so you can't just purely go on weight or BMI itself, so you have to consider the waist circumference.
As you said, what is more important is the body composition, how much muscle mass you have, and your fat mass, fat free mass. So there are ways and means to check those things like body impedance analyzer, DEXA scan. So sophisticated ways of looking at your body composition are there. For your question regarding the prevalence, and we know that our overweight prevalence is somewhere about 25% of the population, adult population, and the obesity is around 9.2, around the range of 10%, quite alarming. So if you take US for example, it's 40%. So high obesity and overweight population is there. We are not there yet, but we have a double burden. On one aspect we have undernutrition, and on another aspect we have overweight and obesity. So this whole term is called malnutrition. So, obesity and overweight is also kind of a malnutrition. Although they have they are enough weight and the muscle, but they are disordered. That is not healthy. That is why we have to play a role in reducing weight in an appropriate way.
Definitely. Now, time and time again, that's what we always try to bring to you, our viewers, some things that which are very common in society, but not properly addressed in the Sri Lankan setup, I would say. Now, which brings me back to something that you mentioned, sir, about this fat percentage. Now, we see there's an increasing prevalence of the younger generation to be more prone towards a healthy lifestyle, and they go to all these gyms, and there are certain equipment which measure your fat percentage. So, for a normal healthy adult, what should be the healthy percentage of fat that they should maintain?
Yeah, it is the composition what I have to stress here.
Yes.
Then so different scales give different values, and they get +1 fat percentage or +2. So it's somewhere about 20 to 25% is considered okay. I mean, if it is less than 20%, it's much better. And what is more important is the visceral fat. The visceral fat is the fat which is attached to your internal organs like kidney, liver. You would have heard the term fatty liver. So it is not only kidney, it is not only liver, even the heart and even the other visceral organs. You have some if that particular fat is more harmful than the subcutaneous fat, which is there in your the belly fat. I mean, I would say that is subcutaneous fat. So therefore, it is always at one point when we see a patient, it is extremely necessary to know about the body composition. From there onwards, we can target a structured program for the patient. That is how we have to go forward if we were to address in a more practical way.
Yes, because before in about couple of years before, how we used to address this was you just stand on a scale, you see that your weight is a bit too much, and then you don't really do an objective assessment.
Correct.
And you just try to reduce your weight, and you wouldn't know what percentage of like you said, the composition, how that should change in a proper healthy way.
Correct.
And so I think this program will be very, very important to all our viewers, from the pediatric to the geriatric population, because this has been a problem across the whole spectrum of ages. Now, moving on with our conversation, sir, we see certain people are more prone towards being overweight or obese. Are there certain risk factors which predispose these people to be obese or overweight?
Yeah, well, of course we are living in an environment, we can call it an obesogenic environment. Our environment is more helpful to gain weight than lose weight. On the other hand, on top of the obesogenic environment, our genes are more prone to we call it thrift genes. So for the same amount of energy for a Westerner, and if you see that for a South Asian, for the same amount of energy we gain more weight. We are more prone, we can easily become fat, we can easily become overweight if we go through that same amount of energy which another person takes in a Western population or a Caucasian population, to be exact. And genes play a major role. Genes play a major role which we cannot modify. So whatever the modifiable factors only we have to target, because gene therapy is not yet available in the field of obesity.
So once again, that's a very interesting point that Dr. Rushdhi emphasizes on. Being South Asians, we are at a disadvantage genetically, where as opposed to the Caucasians, we have a disadvantage where a certain quantified amount of energy will give rise to more fat in our race. So having said that, we have to keep that in mind and work accordingly to live a healthy life. Now, moving on to my next question, sir. We know being overweight or obese is definitely not very healthy, but if we go into the specifics of it, what are the risks, specific risks when we consider from a medical point of view with obesity and being overweight?
Correct. Obesity itself is considered a disease because it will lead to so many other comorbidities. In the sense, obesity is a risk factor for hypertension, diabetes, hyperlipidemia, many cancers, at least 13 cancers are associated with being obese, and arthritis, and it affects each and every system. Say suppose you are an obese person, and you might end up in sleep apnea, so it affects the respiratory system. Then if you are obese and if you get ill and sick, and the repercussions or the after effects are more in a patient with a normal weight. Then again, if you are obese, then you are more prone to cardiovascular effects. So all in all, it affects all the system. It's a multi-system disorder. If you take a young woman of normal age, reproductive age, she might end up in polycystic ovarian syndrome. And polycystic ovarian syndrome, then the only way that we can make it working and to reverse it, the mainstay of treatment is weight reduction. So therefore, in each and every group, childhood obesity also on the rise. Then when it comes to youngsters, then the simple obesity, and then comes polycystic ovarian syndrome. Then comes postpartum difficulty in weight loss. A lot of people after their delivery, they are struggling to lose weight. Then comes the middle age problems, and the diseases associated with the obesity. So all in all, it's a multi-system disorder affecting all the age groups. So it's quite understandable that we have to focus obesity itself as a disease, and of course it is categorized in international disease classification, obesity as a disease.
So I'm sure most of our viewers didn't know that. Now we consider obesity as a disease itself, and quite correctly, as Dr. Rushdhi went on to explain, it has implications in all the systems across all the age groups. So it is very, very important that we understand this, take this into heart, and if we are more prone towards being overweight, obese, take necessary action. Now, sir, we have seen in our day-to-day clinical practice, when certain patients come to us, they say we have so many disease conditions and that is why we are obese. So are there any clinical diseases which leads towards obesity?
Yeah, that is where your medical knowledge comes. As a physician, we have to exclude other causes of obesity, especially when it comes to thyroid illnesses. Hypothyroidism is quite prevalent in the country. Then hypothyroidism is one of the main causes we have to exclude. Then again, a rare condition, I would say, Cushing syndrome, people who are on steroids. Then other, when it comes to children, there are syndromes. And we have to do a basic metabolic panel. We look at all the investigations and we see, basically we do like HbA1c or the fasting blood sugar, then the lipid profile, liver profile. So because sometimes it is also associated with non-alcoholic fatty liver disease, but it may go to NASH, and then it can go to cirrhosis, and it may lead to cancer. Therefore, we have to, in our first visit, we try to get to know the patient. We know that 90% of the obesity in our population is termed simple obesity. If you do all the investigations necessary, you will see all are within the normal range, except a small elevation in ALT, that the liver enzymes. Apart from that, maybe a little bit of the pre-diabetic range, but basically they look normal. So that is what we call simple obesity. Then the diseases, as I mentioned earlier, we have to exclude, and accordingly we have to refer to the appropriate physicians to handle those things in collaboration with management of obesity. It should both go in hand.
So it's not just simply just losing weight, it is to tailor make a treatment package that is suitable for an individual. That's what we advocate, and that is the message that we are trying to bring across to you, our viewers, in this program, because we see obesity being very loosely used across, and we see just a gym workout being advocated to lose weight, but that may not be the case, and it has to be very unique to individual personalities. Now, sir, a patient comes to you, you find them to be obese, and let's say it's a simple obesity. What kind of lifestyle and dietary modifications would you advocate in managing these patients?
That's a very good question. Before coming to that, I would like to address, we have an approach, ABCD approach.
Okay.
The A is anthropometry, as I mentioned, the weight. then the height, then the body composition, the waist circumference, and waist hip ratio. In some cases we all do the anthropometry, then we go for the biochemical, that is the investigations, then the clinical assessment, then we do a thorough clinical examination from the head to toe and systematic examination like respiratory system, abdominal system, locomotor system. We have to examine the patient in a proper way. Then if we identify there are risk factors like insulin resistance, some people you might have noticed the blackening here, we call it acanthosis nigricans, the striae, then the double chin and belly fat, sometimes associated with poor exercise tolerance. Therefore, it is a multidisciplinary approach what we advocate. For example, if we take a good history and if we see that patient is having say sleep apnea, it is my duty as a physician to refer to a chest physician. Then if I do all the workout and I find that there are reasons, endocrine reasons, then I have to refer to the endocrine physician. So vice versa as well. On top of it, sometimes we might need the help of a psychiatrist or a psychologist, because these need lot of behavioral therapy and behavioral modification. Then there should be some social service element also playing on the role, because there's I mean, we are living in a society. So it is a teamwork. It cannot we cannot achieve good results if we work only on isolation. It has to be a feedback between physicians and other healthcare staff. So and also the mother or the wife who will be cooking the stuff. So therefore it involves multidisciplinary teamwork, and there should be a multidisciplinary management, or else a meeting with the family also important when it comes to know the patient. Then when it comes to the dietetic approach, there are so many approaches. If you open the Google or anything, there will be many methods to lose weight. Some people will go for a very low energy diet, some people will say low energy diet, and some people will say there is keto diet, then there is an intermittent fasting. So there are various diets, then paleo, modified paleo. You will be confused, you know, as an ordinary person, what to follow and how to follow. So then you need to, it is okay to read all the stuff, but it is okay to, it is a must to meet an expert in that field, and you have to discuss with them, and you have to come to a structured, individualized plan. That is my message. So, so one shoe will not fix to everybody. We have to tailor make for the patient and his lifestyle.
Yes.
Mind you, there are people who their lifestyle is very fast and very busy. There is no time for cooking. So there is then we have to find some alternate ways. Therefore, it is a difficult question.
So we can't generalize the treatment plans to fit everyone.
Everybody.
So, and as you mentioned about these wives and mothers, I think especially in our society, we feel that showing love is to feed them more, but we have to correct that because
it is quite common when it comes to pregnancy. You know, when they think there are two living beings and they have to feed for two. It is not quite correct. I mean, you know, the baby's weight at the time of delivery is maximum somewhere about 3 or maximum 4. If we say large baby, even then it's 4 kilograms. So it's like 1/15 of the weight of the mother. So you need not to feed for two. But culturally, we think that feeding high calorie, high energy food for those people, then they are at a very bad and at a very disadvantageous situation, because after pregnancy it's very difficult to lose weight. Therefore, each and every stage of life we have to consider the theoretical, more than the theoretical, the practical ways of losing weight.
Now, since you mentioned about these weight problems in each stage of life, I see a worrying tendency among the pediatric population. So, because once again it's a problem with our society and culture, where mothers feel that okay, I need to feed my child with biscuits or sweets, and that is how I show them love, which is leading towards, I think, an increased prevalence of pediatric obesity.
Childhood obesity is on the rise. It is also on the range of 10%, and it will be more in the future. As you rightly mentioned, we have to talk about junk food, and any food which has excess carbohydrates or excess fat or excess salt, we can broadly term as junk food, whether it's homemade or brought from restaurant. It could be even homemade food, but it could become a junk food. The same. Therefore, since you have raised the question of childhood obesity, recently I happened to see a child of 12-year-old who is diabetic, who is hypertensive. So this is the situation here. When I inquired about the sugar intake, I literally counted that that child is taking about 30 teaspoons of sugar per day. I can count and tell.
Yes.
With regard to biscuits, ice creams, then packeted drinks, soft drinks, chocolates, ice creams. So if you count from morning till night, that particular child had 30 teaspoons of sugar per day. So that is the gravity of the problem.
Yes, not to alarm our mothers, but you have to be very well aware that feeding your child excessively is not a way to show them love. Actually, it's doing more harm than good. So like Dr. Rushdhi was saying, just feeding them with biscuits or sweets or ice creams does not really serve any good purpose. It will just automatically make them more prone towards diabetes, and hypertension being lifelong conditions, they will have to face the consequences from a very young age. So that's another important message that we want to bring across to our viewers, because children are more prone towards obesity with the current lifestyle that we have, and of course with the fast food and the fast lifestyle that we have. Now sir, since you mentioned about these keto diets and intermittent fasting, does it really fit our population? Do you think it serves a purpose? If so, how should they practice it?
Correct. Now I will come to the management part of it.
Yes.
The management of obesity, we go for a 3D approach. The first D is the dietetic approach. Then the daily exercises. Then comes the drugs. Those are the medical approaches. Then comes the surgical approaches. When it comes to surgery, there is permanent ways and there are reversible ways of managing obesity. So all in all, diet plays the major role. Diet itself is 80% or 85% responsible for your weight gain. Exercise is helpful to reduce weight, but you might not lose much of your weight due to exercise alone. For example, some people go on a treadmill for 30 minutes. Even you can see that it won't burn more than 250 calories. So same, but if you do it on a regular basis, it is good for your cardiovascular health. So therefore we appreciate exercise, and it has an effect about 10 to 15% of weight loss. With regard to drugs, the FDA approved drugs, only few drugs are available. In Sri Lanka, only I would say only one drug is available. That is also for the people who are more prone to eat fat. So the drug approach is, even then it is 5% weight loss. Even if you go for a drug, it will guarantee only 5% weight loss. So it is a tough task. Then comes the BMI values and your comorbidities and the decision to go for a surgery. So as you know, the surgery is something permanent, except for the intragastric balloon, which is like you put an endoscopic balloon and you keep it for 6 months prior to a surgery or as a motivation. So you can't lose about 20 kilos within 6 months. But generally, if the BMI is more than 40, it is extremely difficult for that person to become BMI of 25. In fact, there was a research done in UK, and they found that out of 245, only one could reverse to 25 if the BMI is above 40. So it's so difficult, and it will lead to so many other comorbidities. Then the surgical intervention is necessary. But we also see that after surgery, that is the sleeve gastrectomy, which is very common rather than the mini gastric bypass or the duodenal switch, there is a relapse. So after about 3-4 years, they regain weight. So therefore the continuous motivation and the continuous follow-up with a nutritionist or a nutrition physician, it's extremely important. The match is not over after doing the surgery. The lifestyle starts at the end of the surgery. So the categories are different, approaches are different. When I come to your question, what is more important is the energy balance, you know. So, we intake food and the expenditure. So, this is the basics of obesity management. And later people found that by reducing calories they did not lose weight. It was a mystery. I mean, people who are on 1200 calories, 1400 calories, despite that they did not lose weight. Then people thought whether we could go for other methods. So, basic reason for that in our population is we never knew about our basal metabolic rate. For example, I do a lot of body impedance analyzer in my clinic in National Hospital, and we find that most of our females, their basal metabolic rate or the resting metabolic rate is not even 1200, sometimes 1150, 1200, maximum even in a healthy active woman it is something like 1300, and we give a diet of 1400 and they gain weight. So, this is what the problem. So, then comes the very low energy diet approach, that is 800 calorie diet, which is very difficult. I mean, we can go ideally for your question, the answer is we cannot hit with one weapon. We have to try several approaches. So, it is okay to try very low energy diet for about 16 weeks and we see the importance. So, they lose nicely. So, this is just an energy balance where you modify your diet. You do not go to restrictive diets or very difficult diets, I would say, like keto and intermittent fasting. I will come to that. But we can go for a low energy diet or a very low energy diet. So, low energy is somewhere about 1000 calories and very low energy is somewhere about 800 calories. Then you motivate the patient and then they will nicely lose about 10 kilos within 4 months. This we have seen. But later the maintenance phase is not so good in our country. In any country I would say, they do not maintain it. It is very difficult because it is a lifestyle change, and we, as I told you, we live in a society, obesogenic environment, a lot of parties and gatherings, and then it becomes maintenance become different. Losing is easy for the first few months, then they lose interest and the lack of motivation. At least these patients, I would say, they should have a continuous interaction with their doctor and it has to be followed. And like you have to motivate them and you have to make them self sufficient to do their workout as well as to understand the science behind losing weight. Then like you are teaching driving to a person, when you it is difficult to teach the driving. Once they know, then they know when to go fast, when to put a brake, when to reverse. So, I mean, then they will fluctuate within 5 to 7 kilos like the rest of the life. Say if his target weight is 70, they can go up and down like 77 and then 75 and all that. So, this can be pretty much doable with low energy diets and very low energy diets. But very low energy diets we cannot go forever, we have to stop within 4 months, then we have to go for it. Then people thought about ketogenic diet. It is a good question. So, I will not say obviously it is bad, ketogenic as well as the intermittent fasting. Ketogenic diet has a long history. It comes from 1921, Dr. Russell, he experimented ketogenic diet on childhood epilepsy and there were successful results, and over the time because of anti-epileptics in the practice, then that was forgotten. The later recently they found that even with 2 or 3 anti-epileptics they did not control the seizures. Then they started ketogenic diets, then they find good results. So, it is a big research area, I would say, even for Alzheimer's, dementia, other neurological conditions people are trying. What they really do, what really this ketogenic diet is, you have to have like a 55 to 60% of fat, then about 30% of protein, and your carbohydrate is less than 50 grams. So, this is the basic approach. So, what is the science behind it is, when you give such a low amount of carbohydrate, then after a few days there is a metabolic switch. You start using your fats and ketone bodies. So, which can be utilized except for the red blood cells and the liver. All other cells can utilize ketone bodies and that will use the fat in your body. So, there is no particular no for that. It is on a short term basis that will be useful, but it has to be under strict medical observation, because they can have dizziness, they can go into faintishness, as well as because lack of carbohydrates, initially they will have hypoglycemia. So, and also sometimes elevated LDL levels. So, it has to be monitored. Then dehydration is a problem, electrolyte imbalances. So, there are so many issues with ketogenic diet, but with a good expert we can, as I told you, that different hits, we can use that as well for an initial weight loss. Then we have to go for a sustainable method. Same applies to the intermittent fasting. This intermittent fasting concept also comes from several religious fastings, where you fast for about a period of 16 hours and then you eat. So, then it has to be, even in intermittent fasting, it has to be fasting and eating, not fasting and feasting. What we see in our community is fasting and feasting. Yes. It is not fasting and feasting. If you really want to get the maximum benefit of fasting, it has to be fasting and eating. Eating, that is mindful eating. So, it has to be like 2 meals, proper meals, and then liquids. And again, that has to be done under medical supervision, because these diets are restrictive diets. These are not normal. So, again, for the intermittent fasting, the concept comes from religious backgrounds, as well as we were in the past, we lived with the famines and all, and people gather food, they ate when they had, they didn't eat when they didn't have. So, that all is related. There are studies, I mean there are meta-analyses, there are a lot of studies going on intermittent fasting. Intermittent fasting at times useful, very useful, but again there are so many varieties of intermittent fasting then there are 5-2, 4-3, several methods. As I told you, as I am stressing again and again, one particular method will not work for everyone. Also, we have to use several methods for the same person, and we have to find the right balance for the person. And we should not forget the maintenance phase, where you need to do exercises, muscle building, all that is necessary. So, this is a very interesting field, to be honest. Every time I see a patient, it is a different story, and it is a different kind of weight loss which they expect. Different expectations, you know, not everybody wants to become a hero or heroine. So, there are social aspects. So, we have to address everything in such a way.
Definitely. Now, even I myself learned so much by just listening to Dr. Rushdhi, and I am sure you, our viewers, would have learned so much, as in specifically he went on to describe how these diets came into being, the historical aspect of it, and how one shoe does not fit all. And it is a work in progress, it is a multidisciplinary approach, where you have to consider each person as unique and tailor make these regimes to fit that person. So, that is the message that we want to bring to you today in our discussion about obesity. So, with our time constraints, we have to wind up, but before we wind up, I just want to ask from you, obesity is a very big problem, and we discussed somewhat in depth about this, but before we wind up, what is your message to our viewers? Most of them might be struggling with this day in and day out. So, before we wind up, what would you like to say to our viewers?
My main message for the viewers is, consider obesity as a disease, and it is your body, and you are responsible for your body, and it will lead to many other diseases. It is not to frighten you, but losing weight is always helpful, and you look good and you feel good, and you can prevent more diseases. So, therefore, take it seriously, and take it as a challenge, and take it as a lifestyle change or lifestyle modification. Then you will enjoy your weight loss and you will sustain it. It is not just one-off visit to a doctor and get a diet chart. These are old style and old school. We have to understand that this is my problem. This is not the problem of my mom or my father or my wife or the doctor's problem. Sometimes purely it is a doctor's advice they come to you. But it is basically take the courage and be strong and think that you can do it and you can achieve it with right advice and the correct follow up. Thank you very much, Dr. Dilshan. Thank you very much, viewers.
There you have it. Obesity is a disease and it will lead towards so many other conditions, which will have debilitating and sinister effects on your body. So, as Dr. Rushdhi says, take courage. Match is not over with just one visit to your doctor, and it's not, like he says, your mother's or your wife's or your children's problem, it's your problem. So, take that message into heart and let's fight obesity together. With that message, I would like to take your leave from this episode of Healthline. Until we meet you again next week with your weekly dose of wellness, this is me, Dr. Dilshan Fernando, signing off, wishing all our viewers Ayubowan.
Thank you.